A 26-year-old female has pain and swelling in her upper jaw. Check out the full workup and surgery today on the open reduction. Welcome to the Open Reduction, your channel covering all topics oral and maxillofacial surgery. I'm Dr. Tom Bolten, and today we are exposing, draining, and removing a lesion in a patient's upper jaw. This patient is a 26-year-old female who has pain and mild swelling in her right upper jaw, superior to teeth 6, 7, and 8. There is mild edema in the maxillary vestibule, but there is no fistula. Teeth 7, 8, and 9 are endodontically treated. I obtained a cone beam CT, and there's a large radiolucency in her anterior maxilla. This lesion is well defined and it appears to have fluid within it. It extends from the right premolar to the left central incisor. Since this lesion is superior to 3 root canal treated teeth, there's a pretty good chance that this is a chronic infectious process. But this could also be a cyst within the maxilla that has subsequently become infected. The only way to know and to treat this lesion is to open the site, remove it, and submit the tissue to the pathologist. This procedure is done in the office under IV sedation. Once this patient is asleep and I've numbed the area, I aspirate to make sure this isn't an arteriovascular lesion. There is minimal fluid when I aspirate. Next, I make an incision along the sulcus and a distal release behind the premolar. I elevate the papilla and create a full thickness flap below the periosteum. There is fibrous tissue superficial to the lesion where it is broken through the bone, so I free the flap with a 15 blade. I then continue the dissection. Here is the exposed site, and we can see where this lesion is perforated through the labial bone. I need better access to this lesion, so I create a bony window with a round burr. I remove the fibrous tissue with a rongeur. I perforate the lesion and we can see a relatively clear fluid within the lumen. I don't quite have the access I need, so I remove additional bone, being very careful not to damage the roots of the adjacent teeth.
We got one with it.
I use a curette to dissect this lesion off the bone, and as I'm doing this, more clear fluid is spilling out. This clear fluid suggests Streptococcus bacteria. Staph infections are much thicker, creamier, and have a yellowish white appearance. Once I have freed the lesion, I use a rongeur to remove it. Here it comes, but I can tell this lesion is friable and will easily tear. So I go back in with the curette and free it from the bone. I grab it again with the rongeur and remove the majority of the lesion. There is still a portion left, which I secure with the rongeur and remove as well. Now, I aggressively curette the bone cavity to confirm the lesion is removed. Once I'm satisfied, I rinse the cavity and thoroughly inspect it. The site is clean and I'm looking at healthy bone. Now, I drape the soft tissue over the bony window. I close with interdental sutures. Here is the final closure. This site healed very well and the patient felt much better with this lesion removed. I saw her back after 1 month to ensure appropriate healing. The pathology came back as an inflammatory cyst, which is a cyst that forms around a chronic infection. The next step is to identify which tooth is causing this infectious process, which will be established at the endodontist office where she had the root canals performed. The offending tooth will need an endo retreat or potentially an extraction. Thanks so much for watching. Please click those like and subscribe buttons and check out my channel and my website for all kinds of interesting oral and maxillofacial surgery content. I'm Dr. Tom Bolten. I'll catch you next time on the Open Reduction.